Good afternoon, everybody, and it's nice seeing you again. So today we want to look at cardiovascular pharmacology, and we'll look at hypertension for some minutes. So the first question is, what is hypertension? We discuss hypertension to be a consistent increase or a sustained increase in what? In blood pressure, either the systolic or the diastolic or both. So you can have hypertension as systolic or diastolic or both. Now, so we expect that for a normotensive person or a patient that your blood pressure reading should not exceed 120/80 mmHg, and for prehypertension, anything from 120/80 to 129/80 still will be classed as prehypertension, while stage 1 will start from 130/90 to 149, to 149/90 still. Anything above 150 will be classed as stage 2 hypertension, 150/100. Now, from there, we can come to, before we talk about drug therapy, look at some of the terms we talk about peripheral vascular resistance. Peripheral vascular resistance is the pressure that builds up in blood vessels. So this is the pressure that resists blood flow. Then, if we can reduce peripheral vascular resistance, we can reduce what? The blood pressure. The other thing to note here is the cardiac output. The cardiac output is the quantity of blood the heart pumps out, and the cardiac output is also a function of the stroke volume and the sympathetic inflow into the heart. So blood pressure is expressed mathematically as what? The multiplication of what? The cardiac output and the peripheral vascular resistance. Briefly, we want to discuss the drug therapy. For the classes of drugs that are used, we have the preferred, the alternative agent, and the adjunctive agent. For the preferred, we have diuretics and beta blockers as the preferred drug classes. For alternative agent, we have the ACE inhibitors, ARBs, CCBs, then alpha-1 adrenergic blockers. For adjunctive agent, we look at the central acting alpha-2 agonists, direct vasodilators, peripheral acting adrenergic agent, and there are some other agents that we have: the direct renin antagonists like aliskiren, the aldosterone antagonist like eplerenone, and the ganglionic blockers, e.g. hexametonium. Now, nurse responsibility will include what? You need to check the blood pressure of the patient before you start therapy and during therapy. You check before therapy because you want to be sure this person is hypertensive. You check during therapy to ensure that this person has not gone from hypertension to hypotension. Then we need to check the pattern of bowel elimination because some of the drug classes like the CCBs, calcium channel blockers, can cause constipation. We'll also look at is the person already coughing? Any condition that has a cough, as maybe tuberculosis or any other condition, you will not want to use some classes of drugs here, especially the ACE inhibitor, because ACE inhibitors also produces cough due to the release of bradykinin, which is also a vasodilator. Then you want to check for pregnancy because most of these drugs are not safe in pregnancy, except for maybe meltidopa that is highly recommended in pregnancy. Then medication history, you want to be sure that the medication the individual is currently on will not affect the drug you're about to give. For example, we do not give TCAs, tricyclic antidepressants, with alpha adrenergic blockers because you're going to have a problem if you give those two drugs together. Then other underlying condition, maybe asthma, COPD, or other cardiovascular issues, you want to be sure. Then you also want to review the results of the lab test. Quickly, adverse effects and side effects. Some of the adverse events that might accompany any of these classes would be headache, nausea, diarrhea, dyspepsia, hypotension, vertigo, cough, cramps, constipation, impotence, sexual dysfunction in men, increased prolactin secretion, hypokalemia, gynecomastia, tachycardia, or reflex tachycardia, then weakness, general body weakness, or syncope. Okay, before we discuss some of the other drugs, I want to quickly talk about the RAS. What is the RAS? The RAS stands for the renin angiotensin aldosterone system. Usually, once we have any of these conditions here, hypotension, low renal blood flow, reduced blood volume, this will usually lead to the release of renin. Renin will activate angiotensinogen, which comes from the liver, to angiotensin 1. So angiotensin 1 will need to be connected to angiotensin 2 by the angiotensin 1 converting enzyme. So there is one of the drug class that prevents the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 itself is a potent vasoconstrictor. Then angiotensin 2 also would at some point affect the release of what? Aldosterone, which is a potent sodium, it helps to retain sodium and water retention, which will also cause the blood pressure to shoot up. Okay, now coming to the first drug class here, we have ACE inhibitors. ACE inhibitors are called what? Angiotensin converting enzyme inhibitors. What did this drug class do? Just like captopril, lisinopril, and enalapril, what they do is they prevent the conversion of what? Angiotensin 1 to angiotensin 2. So once you prevent that conversion, so that means renin will not be released to activate what? Angiotensinogen. The angiotensinogen to be converted to angiotensin, that will not call angiotensin 1 to 2. Rather, so once you prevent that conversion, this drug will prevent the vasoconstriction that comes from conversion of what? Angiotensin 1 to angiotensin 2. Then we're supposed to know that usually we don't give ACE inhibitors for pregnant women, and that this drug class, because of the release of bradykinin, they normally would cause cough that is not seen with ARBs, right? So that's not seen with ARBs. Quickly, I'll just talk about the ARBs. ARBs are known as the Angiotensin II Receptor Blockers. So the drugs here, they function by preventing the binding of what? Angiotensin II to its receptor. Once you do that too, you would prevent vasoconstriction and also prevent the release of aldosterone, which is a potent that helps to retain sodium and prevent water loss. So examples here are the candesartan, losartan, valsartan. These two drug classes are classed as alternative drugs. So they can be given as a single agent, or they can be given as what? As a part of what? Part of the drugs you're given. Quickly, I'll talk about the alpha 2 agonists here, especially the metidopa and clonidine. Metidopa is recommended for pregnant women that have high blood pressure. What we have there, metidopa will prevent the sympathetic outflow from the brain. It prevents the release of noradrenaline from the brain, so which will now produce peripheral effect that will cause the blood pressure to go up. So by giving this drug, which in a way will help to block that outflow, it means that you do not get that sympathetic outflow on the heart that will cause the blood pressure to go up. It blocks sympathetic outflow from the CNS to the heart generally. Then we have alpha 1 adrenergic blockers. Alpha 1 adrenergic blockers act on the alpha 1 receptors on blood vessels, the smooth muscles here. So it causes alpha 1, by stimulating the alpha 1 receptor, what you produce is vasodilation. So by giving alpha 1 adrenergic blockers, what you end up producing is that what you produce vasodilatation. So the drugs here are mainly, most of them are prazosin, telazosin, and diazosin. So we have alpha 1 adrenergic blocker that is given to reverse vasoconstriction that will have had at alpha 1 receptor. So what produces alpha 2? So these drugs are also used in men to reverse or to help manage a condition known as prostatic hyperplasia, where it causes the relaxation of the smooth muscle of the blood vessels around the bladder. We have that there. Okay, then for this drug, we now look at the CCBs. These are the calcium channel blockers. Calcium channel blockers. We have nifedipine, amlodipine, verapamil, diazoxide as typical examples. Usually, we give nifedipine and amlodipine in hypertension because they tend to produce a greater response. They tend to reduce, as vasodilators, they tend to reduce the peripheral vascular resistance. By reducing peripheral vascular resistance, this will cause the blood vessels to become more dilated. It also helps with rhythm in the heart and contraction of the heart. The other drugs that can could be verapamil and diuretics. Quickly, I'll be talking about the direct vasodilators here. We have hydralazine, minoxidil, and sodium hydroxide. These class of drugs are given as adjunctive medications. They are not preferred, and they are not given as an alternative. Usually, they are just adjunctive because all they tend to do is what they cause vasodilation, which is usually for a short period, unless you add another drug to prevent um, sympathetic inflow into the heart. So once this drug, alprazolam will cause arterial vasodilatation, minoxidil will also cause arterial vasodilatation, whereas sodium hydroxide will cause both arterial and venous dilatation. So the minoxidil also has the other advantage that it causes hypertrichosis, which in some areas of the body that increase hair growth in some of the areas of the body, but generally will cause what? Dilatation of the blood vessel. This is transient. You only increase this effect by adding maybe a beta blocker or another agent that will block the reflex tachycardia that accompanies this drug class. Okay, coming to the diuretics. Usually, diuretics are, well, like 5 different classes of diuretics, and the two major ones that are used as first-line drugs are the thiazides, e.g. hydrochlorothiazide, and these drugs are very, very effective when creatinine clearance is still above 30 mL per minute. So, what do they do? They will cause what? Increase in salt and water excretion, which will ordinarily cause the blood pressure to drop. From there, we'll look at the loop diuretics, e.g. the furosemide or furosemide. These drugs are more potent and are given once the um, renal creatine clearance drop below 30 mL per minute. So, but this drug also might cause the loss of potassium ion, leading to hypokalemia. So usually, there might be need to add what? A potassium sparing diuretics to the usage of these drugs. So what it is, spironolactone or amiodarone will prevent the loss of potassium ion once you give what? Diuretics. So prevent the loss of potassium ion during this therapy. Okay, and some of the other effects I don't want to discuss here. The other drug I think I'm not speaking about would be the beta blockers. The beta blockers would reduce cardiac output. This drug class will reduce cardiac output. Example are the shavedilol, lobetalol, propranolol, atenolol, etc. Lobetalol seems to is both an adrenergic an alpha and a beta blocker. It blocks both the alpha receptors and the beta receptors. So, propranolol seems to block both beta receptors. Atenolol and kedol seems to be more specific for beta receptors. So, we could give this drug to reduce what? To reduce cardiac output. So, from initially we said that what? For you to control blood pressure, you just need to modulate either the cardiac output or the peripheral vascular resistance. So this drug can easily reduce the workload on the heart. because they reduce what cardiac output. But the problem with beta blockers is that you need to check if the patient has what, if the patient is asthmatic or has COPD or has other issues that affect that may affect maybe insulin or insulin metabolism. But once those things are not there, you can keep beta blocker. And also, beta blockers have been proven to be less effective in blacks, in Africans. So you really want to be careful with the use of beta blockers generally. But for the first line drugs that we talked about, we have the diuretics and beta blockers there. So you can now switch with the other classes of drugs. So most of the adverse events you see are compressed here, loss of responsibility there, and generally we have this. Then we said that diuretics would always produce what we call an addictive effect or a synergistic effect with other drug classes, whereas alpha 1 adrenergic agent 2 are also used in patients that already has low renal blood flow. It does not seem to impact low renal blood flow. So patients that already have problem with renal blood flow, we can also give alpha 1 adrenergic blockers. There are other drugs that we didn't mention here, maybe the ganglionic blockers that would block both the sympathetic and the parasympathetic supply to the body. And these drugs are now more of they have more of maybe experimental value or historical value. They are no longer in use. Just like guanidine or rezepine that tend to deplete the store or prevent the release of noradrenaline from the store or from their storage sites. Beyond that, most of these drugs are used to control hypertension. Usually, you expect to start with what monotherapy with the patient. So once a drug do not produce that result, you can now think of adding a second drug to help control blood pressure. So I think with this, we can wrap it up here. Yeah, thank you. How many minutes?